The emergency alarm blared through forward operating base Sentinel when the young doctors saw Captain Lena Harlow picking up the 30-kilogram trauma pack. "Ma'am, you might want the lighter medical kit," Lieutenant Brooks called out, his smirk barely hidden. "That combat pack requires upper body strength most support staff don't have." His buddies laughed, watching the woman they assumed was just another hospital administrator pretending to be a field medic. What they didn't know, and what they were about to learn when 4 critical casualties landed on that helipad in exactly 12 minutes, was that Captain Lena Harlow had saved 89 lives under fire across 3 combat deployments, held a 3.2% mortality rate against the 15% average, and was the trauma surgeon who'd trained half the Special Forces medics in theater when she calmly strapped on that pack and prepared to show these rookies what a real combat doctor looked like. She had no idea their commanding general was about to walk through that door and turn their mockery into the most humbling moment of their medical careers. Captain Lena Harlow, 28 years old, with light brown hair pulled back in a regulation military bun and calm blue eyes, was checking emergency equipment. She'd been a field surgeon for 6 years, but every new base meant the same experience, starting from zero. It was her first day at Forward Operating Base Sentinel. 8 newly assigned doctors, all from civilian hospitals, all with basic military training, had been assigned to the field hospital. The base's chief medical officer, Colonel Marcus Webb, had briefed her. "Dr. Harlow, these physicians are technically qualified, but none have worked under fire. Most were trauma surgeons pre-military. Good ones. But combat medicine, it's different. We need to test them." "Understood, sir," Lena had replied. "Standard evaluation protocol?" "No." Webb had shaken his head. "Real test. Helicopter drill in 2 hours. 4 simulated trauma cases. Take them, let them work under your leadership. See how they handle pressure." Now in the equipment room, when Lena picked up the 30-kilogram combat medic pack, the mockery had started. "Careful, doctor," Brooks said, muscular with a Texas accent. "That pack's loaded with combat field equipment, tourniquets, decompression needles, IV kits, surgical instruments. 30 kilos fully loaded. Can you really lift it?" Another young doctor, Lieutenant Park, added, "Yeah, ma'am, maybe start with the standard medical kit. Field equipment is heavy, not what most hospital doctors are used to." Lena easily shouldered the pack. She'd carried it every day for 6 years. "I can manage." She opened it and systematically checked. 6 tourniquets, arterial bleeding control, 12 hemostatic gauze pads, rapid clotting, 4 chest decompression needles, tension pneumothorax, 8 IV kits, fluid resuscitation, 2 surgical sets, emergency procedures, airway management equipment, vital monitor. She held each piece of equipment, checked its placement with professional efficiency. This equipment had saved 89 patients. She knew every item's location in her sleep, but Brooks persisted. "Seriously, ma'am, please don't take this wrong, but that equipment probably has more combat experience than you. Maybe let one of us demonstrate proper usage. Field medicine, it's different. Very different from hospital surgery." The implication was clear. They thought she was a hospital surgeon. Good maybe, but definitely not a combat doctor. Lena did what she always did, stayed quiet, and decided to let the equipment do the talking. "I'll make you a deal," she said calmly. "We have a helicopter drill in 2 hours. 4 simulated trauma cases. I'll take the first. You watch. Then you'll try. Whoever performs best leads. Fair?" Brooks smiled confidently. "Very fair, ma'am." "What are the criteria?" "Simple. Time, accuracy, patient survival, standard combat metrics." The doctors immediately agreed. They had no idea the quiet woman in front of them had graduated top of her class from Special Forces Combat Medic School, saved 89 critical patients across 3 combat deployments, and trained Navy SEALs and Army Rangers. They were about to find out. 2 hours later, 4 advanced trauma mannequins were set up in the training area. The sound system would simulate battlefield conditions. Colonel Webb explained. Scenario: bomb attack. 4 casualties, varying severity. You need to triage, determine treatment priority, and stabilize. Lena picked up her pack. Ready to begin, sir. Webb nodded. Sound system starting. Timing now. Boom. Simulated bomb sound. Then continuous noise, screaming, radio cacophony, gunfire. Lena moved. 0 to 15 seconds. Try age. She quickly scanned all 4 mannequins. Trained eyes, rapid assessment. Mannequin 1, arterial bleeding, conscious, critical but stabilizable. Mannequin 2, chest wound, respiratory distress. Immediate mannequin 3, fracture, stable vitals. Delayed mannequin 4, no pulse, no breathing. Category 4, dead decision. Mannequin 2, first, life-threatening. Then mannequin 1, 15 to 45 seconds. Mannequin 2, chest injury. Grabbed chest decompression needle from pack. Second intercostal space, mid-clavicular line. Inserted needle. Air release. Tension pneumothorax resolved. Immediately followed with chest tube. Placed, secured, breathing improved. 45 to 90 seconds. Mannequin 1, arterial bleeding. Applied tourniquet. Femoral artery, tight. Bleeding stopped. IV access. Found vein first attempt. 18-gauge catheter. Fluid resuscitation started. Hemostatic gauze applied to wound. Pressure bandage. 90 to 120 seconds. Vital check. Rechecked both patients. Vitals stable. Bleeding controlled. Breathing adequate. 120 seconds. Complete. Lena stood, hands covered in simulated blood but calm. 2 critical patients stabilized. 1 delayed. Will need surgery. 1 category 4 inches. Webb stopped the timer. 2 minutes, 3 seconds. Perfect triage. Perfect procedure application. 8 young doctors stared in shock. Now, Lena said calmly, who wants to try first? Over the next 2 hours, all 8 doctors attempted the same scenario. Brooks. Attempt 1 started confidently. Did triage. Correct prioritization. Good start. Moved to chest decompression. Grabbed needle. But under sound pressure, hands trembled. First attempt went to wrong location. Second attempt successful but time lost. Moved to arterial bleeding. Tried to apply tourniquet, but not tight enough. Bleeding continued. Panic signs. Where's the hemostatic gauze? Fumbled through pack. Time passing. Total time, 8 minutes, 45 seconds. In a real battlefield, Lena said gently, your first patient died at the 4-minute mark from blood loss. Second died at 6 minutes from respiratory failure. Brooks's face went pale. Park. Attempt 2. More careful but slower. Triage good. Procedures technically correct. But coordination lacking. Delays between steps. Total time, 11 minutes, 20 seconds. Others. Best time, 7 minutes, 15 seconds. Lieutenant Morrison. Worst, 14 minutes. Panicked, gave up. Average, 9 minutes, 38 seconds. Lena's time, 2 minutes, 3 seconds. The gap was devastating. 8 doctors now silent. Laughter gone. Looking at Colonel Webb, wondering what would happen. Just then the door opened. Colonel Webb entered. Behind him, a 3-star general, Patricia Morrison, commander of Army Combat Medic Command. Doctors snapped to attention. At ease, Webb said, turned to Lena. Dr. Harlow, how did the evaluation go? Simulation complete, sir. Results recorded. General Morrison looked at the training area. 4 mannequins. Used equipment. Young doctors' demoralized faces. Was Dr. Harlow a good instructor, she asked. Brooks spoke, voice respectful. Sir, she was incredible. Stabilized 2 critical patients in 2 minutes. Our best took 7 minutes. Morrison nodded. Do you know Dr. Harlow, gentlemen? No, sir. We only knew she was assigned today. Morrison turned to the doctors. Let me introduce you to Captain Lena Harlow. 3 combat deployments, Afghanistan twice, Iraq once. Total 18 months in combat zones. 89 critical trauma cases stabilized under fire. Mortality rate 3.2%, compared to the 15% peer average. Special Forces Combat Medic School graduate, top of her class, in a program with a 58% failure rate. Trained Navy SEAL, Army Ranger, and Delta Force medics. Over 200 special operations personnel. 2 Joint Service Commendation Medals, 1 for saving 12 patients under fire alone. Morrison continued, but here's what matters most. Dr. Harlow is the most effective combat surgeon I've commanded in 30 years of military service. Her understanding of trauma medicine, decision-making under stress, and performance under pressure. She paused for effect. And you asked her if she could lift a 30-kilogram pack. The doctors' faces went from confused to mortified. Brooks swallowed hard. But more importantly, Morrison added, you told her hospital doctors aren't used to field equipment. Dr. Harlow is not a hospital surgeon. She's a combat surgeon. The difference: hospital surgeons work in operating rooms. Combat surgeons work where bombs are falling. Colonel Webb interjected, Dr. Harlow doesn't advertise her credentials. She believes doctors should prove themselves through performance. But I think today's performance made things quite clear. Lena remained at ease, expression professional, neutral. Morrison turned to Lena. Dr. Harlow, I came to discuss your Fort Sam Houston assignment. But first, I want to see you give these doctors real training. Yes, sir. Morrison looked at the doctors. Gentlemen, you're about to receive world-class training. I suggest you pay attention because Dr. Harlow will expect more from you. And if you don't meet expectations, you won't be worth anything on a battlefield. Over the next 4 hours, Lena conducted a masterclass. Scenario 1, multiple trauma coordination. On a real battlefield, Lena said, you never see one patient. A bomb doesn't injure one person. It injures 10. Triage isn't just priority. It's resource management. New scenario, 6 patients simultaneously. 2 critical, 1 salvageable, 1 not. 3 serious, all stabilizable. 1 minor. The problem, Lena said, you have 2 doctors, limited equipment. You must decide. Spend time on the unsalvageable critical patient and lose 3 serious, or abandon him and save 4. Doctors looked uncomfortable. They'd never thought this way. This isn't cruelty, Lena said quietly. It's triage reality. You must accept losing some patients to save more lives. Lena demonstrated, assessed 6 patients in 20 seconds, instantaneous decisions. Patient 1, unsalvageable critical, morphine comfort, no other treatment. Patient 2, salvageable critical, immediate intervention, chest tube, IV, stabilization, 2 minutes. Patients 3, 4, 5, serious, sequential, tourniquet, 4, pressure bandages, 90 seconds each. Patient 6, minor, self-care instructions, total 9 minutes. 5 patients saved. Brooks tried, couldn't emotionally abandon first critical patient, unsalvageable. Spent 8 minutes. Patient still died. By the time he reached other patients, 2 serious patients had died from blood loss. Result, saved 2 lives versus Lena's 5. See, Lena said, emotional decisions cost lives. On battlefields, the hardest decisions are the right ones. Scenario 2. Surgery under fire. Now real conditions, Lena said. Continuous enemy fire, explosions, radio cacophony, and a patient dying from chest injury. Sound system started. R-A-T-T-A-T-T-A-T. Tac, 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 tac. Automatic weapon fire. Radio. Contact, contact, enemy right flank. Explosion simulations. Subwoofer making building feel like it was shaking. Lena demonstrated completely ignored noise. Hands steady, breathing controlled. Chest decompression, tube placement. IV access, vital monitoring. An explosion simulation happened. Very close, very loud. Lena didn't even blink. Continued procedure. 3 minutes, 15 seconds. Patient stabilized. Brooks tried. First 10 seconds okay. Then big explosion simulation. Hands trembled. Dropped needle. Damn. Tried to recover, but concentration broken. Noise overwhelming him. 9 minutes, 40 seconds. Patient died. The problem, Lena said, you're listening to the noise. Noise doesn't matter. The only thing that matters is the patient under your hands. You must learn to shut out the rest of the world. Scenario 3, limited equipment crisis. Final scenario, Lena said. Real case, 2012, Helmand Province. Bomb attack, 8 casualties, but our ambulance was hit. 70% of our equipment gone. We had 3 tourniquets, 1 chest tube, 2 IV kits, some gauze. That's it. 8 patients, minimal equipment. How do you decide? Doctors were shocked. That's impossible. No, Lena said calmly. Difficult, but doable, because I did it. Saved 6 of 8 patients. Lena demonstrated resource optimization. Tourniquets only for arterial bleeding. Venous bleeding can use pressure bandage. You can use shirt pieces. Chest tube only for tension pneumothorax. Simple chest wounds can be treated with occlusive bandage. Use plastic bag. IV not necessary for every patient. Conscious patients can take oral fluids. Creative medicine, field improvisation. Lena maximized every resource. Stabilized 8 patients in 18 minutes. Minimal equipment. 7 saved, 1 too far gone. Doctors tried. Best saved 4 patients. Most 2 to 3. Didn't know strategic equipment use. You see, Lena said, combat medicine isn't about resources. It's about creativity. If you can see everything as a tool, shirt becomes tourniquet, plastic bag becomes chest seal, you can save lives. Hour 4 of training. Real emergency came. Colonel Webb ran in. Lena! Real trauma. Training exercise accident. 4 casualties. 2 critical. Helicopter arriving in 10 minutes. Lena immediately moved. Grabbed equipment. Brooks Park with me. Others observe. Ran to helipad. 8 minutes later, helicopter landing. Black Hawk landed. Doors opened. 4 casualties extracted. Lena immediately triaged. Casualty 1, minor, arm fracture. Casualty 2, serious, leg trauma, bleeding. Casualty 3, critical, chest crush, respiratory arrest. Casualty 4, critical, head trauma, unconscious. Lena commanded, Brooks, take casualty 2. Bleeding control, start IV. Park, monitor casualty 4. Do GCS, Glasgow Coma Scale. I'm handling casualty 3. Casualty 3, chest crush, young soldier, maybe 22. Crushed in armored vehicle exercise, no breathing, pulse very weak. Asymmetric chest movement. Lena placed her hands, felt fluid in left chest cavity, hemothorax, blood pooling. Decision chest tube, urgent, quick betadine clean. No local anesthetic, no time. Blunt dissection with finger. 5th intercostal space. Felt chest cavity with finger. Inserted chest tube. Blood flowed. 800 milliliters. Bad. But chest expanded. Intubation. Airway secured. 4, 2 lines. Fluid resuscitation. Vital monitor. Pulse returned. 60, 70, 85. Breathing machine assisted. 4 minutes, 20 seconds. Patient stabilized. Ready for ambulance. Brooks and Park had stabilized their patients. Lena's training worked. 4 patients alive, all transported to hospital. On the helipad, as Lena cleaned her hands, Brooks approached. Dr. Harlow, ma'am, that was incredible. I watched. How you placed the chest tube. You felt with your hand without seeing. How did you know where to put it? Experience, Lena said simply. I've done it 89 times. Some in darkness, some under fire, some in helicopters. When you repeat it enough, hands work automatically. Park added, "Ma'am, I need to tell you something. When you arrived today, I was skeptical. I'd never seen a female field surgeon, and you're so calm. I thought maybe you're a civilian hospital doctor, can't handle real pressure." He paused. "I was completely wrong. You're the best trauma doctor I've ever seen. You made me a better doctor." "Thank you." Lena nodded. "You had doubts but stayed professional and focused on learning." "Exactly the right approach. Use that when you return to your unit. Judge doctors by performance, not assumptions." That evening, General Morrison met with Lena. "Dr. Harlow, we want you as lead instructor at Fort Sam Houston, Advanced Combat Medicine Program. All services. You'll shape military combat medicine's future." Lena hesitated. "Sir, there's always resistance. Some don't want a female lead." Morrison leaned forward. "That's why we need you. Professional students get world-class training. Others adapt or fail. Either improves the force." "I'll do it, sir. One condition: every student with wrong attitudes gets today's treatment. I demonstrate. They fail. They learn." Morrison smiled. "Perfect." 3 months later, 40 students, best from all branches. Front row Marine, skeptical smile. Lena addressed it. "Questions about your instructor?" "I'm female, smaller than most." "Doesn't prevent teaching." "Questions?" Marine. "Ma'am, what qualifies you?" 6 years combat, 89 patients, 3.2% mortality rate, 200 plus special ops trained. Judge me by your improvement, not my resume. No one spoke. Week 1, rebuilt fundamentals. Tourniquet application 100 times. Week 3, cricothyroidotomy. After 100 attempts, students mastered it. Week 6, helicopter trauma simulation. Class average improved from 12 minutes to 4 minutes 20 seconds. Week 9, real hospital rotation. Mass casualty. 5 patients stabilized in 18 minutes. All saved. Week 10, Marine approached. "Ma'am, I had doubts. You're the best instructor I've ever had. Changed how I think about medicine." Final evaluation. Lena students, 90% survival rate, 16 minutes 40 seconds average. Traditional training, 72% survival, 24 minutes average, 25% better performance. General Morrison, Major Harlow, you revolutionized combat medicine. I'm promoting you to develop Army-wide curriculum. Major Lena Harlow, Master Combat Medicine Instructor, trained 1,200 plus medics. Curriculum adopted by 15 nations. General Morrison at ceremony. Major Harlow proved excellence has nothing to do with demographics. Everything to do with knowledge and determination. Young female lieutenant approached. "Ma'am, I'm first woman selected for medic school. Some say I'll fail. How did you handle that?" Lena. Use doubt as motivation. Master fundamentals, so assumptions become irrelevant. When you succeed, you make it easier for the next woman. 10 years later, Lena returned as colonel. Guest speaker, 8 women in the class, unheard of a decade ago. Medics stood with pure professional respect. Lena picked up the 30-kilogram pack. This equipment doesn't care who holds it, only responds to fundamentals, practice, and refusing imposed limitations. She made a promise. Excellence is available to anyone willing to do the work, because Colonel Lena Harlow proved the best trauma doctor in any room might be the person everyone underestimated, until she saved lives and proved everyone wrong. If you enjoyed stories of hidden heroism and life-saving, subscribe to Shadowed Glory Stories.